You know, Stephen Hawking, reflecting on his life with ALS, said something quite striking. He said, "Apart from being unlucky enough to get ALS, I have been fortunate in almost every other respect." And he credited the help and support he received. That really hits home, doesn't it? It tells you right away that dealing with a chronic illness, adjusting to it, is so much more than just a physical thing. And that's exactly what we're going to dig into today. We're exploring the really deep psychological and social journey people take when they're adapting to chronic disease. We're drawing on a big review from the Annual Review of Psychology to help us unpack it all.
That's right. And our goal here isn't just to talk about coping in a simple way. We really want to explore what adjustment truly means in this context. It's complex. We'll look at the factors that seem to help, the ones that hinder, and maybe figure out what allows some people to, adjust well, even when facing huge challenges. Hopefully, this will give you, our listener, a much richer feel for the human experience behind it all.
Okay, so let's start right there. What does it mean to adjust? We often think medically, right? How are the symptoms? But the research, it paints a much broader picture.
It really does. It's way beyond just the disease not being active. True adjustment, it seems, is this whole person's state. It means things like really mastering the day-to-day tasks, the illness demands, meds, managing symptoms, and keeping up your functional status, staying independent as much as possible. And crucially, it's about your perceived quality of life, not just physically, but socially, emotionally too. Plus, the absence of major psychological issues like depression or severe anxiety, and generally low negative feelings, not being constantly sad or angry. But what's really interesting in gaining traction in research are the positive sides of adjustment. Like, can you still maintain a positive mood? Can you find purpose? The idea is that having a disease doesn't automatically rule out joy or growth. It's not just about not being distressed. It's about actively finding well-being.
I like that focus on the positive because the source also brings up this phrase, the tyranny of positive thinking, this pressure to always be strong. That sounds like it could actually be harmful.
Oh, absolutely. It can
Yeah.
be a real trap. This idea that you have to be upbeat all the time. It leaves no room for bad days or just feeling overwhelmed. It can make people feel like they're failing if they're struggling.
Hmm.
And this notion that negative thoughts will worsen the disease, well, that just adds guilt to everything else. Plus, adjustment isn't like climbing a ladder. You don't just reach the top and you're done. It's dynamic. Diseases change. Cancer might recur. You might have another heart attack. Arthritis flares up. Each time, you have to readjust. It's an ongoing process.
That really highlights how different everyone's experience is, too. Even with the same illness, people adapt so differently. The sources talk about islands of disruption, which I found interesting. Like, the illness hits certain parts of your life hard, but maybe not everything collapses.
Exactly right. That heterogeneity is key. We see it in studies all the time. Take women with breast cancer. Some studies show distinct groups. Some maintain a pretty high quality of life throughout. Others start lower but improve over time. Some dip and then recover quickly. And then there's a group that unfortunately shows a significant decline. Or look at heart transplant patients. Research found some had consistently low distress, others consistently high, and some just fluctuated quite a bit over the years. It's definitely not one size fits all.
Okay, so we understand adjustment is complex and varied, but what actually influences it? Let's start broad. What about the bigger societal factors, the distal influences, as the research calls them?
Right, the distal factors. Socioeconomic status, or SES, is a really big one. There's a clear pattern. Lower SES generally links to poorer health outcomes. And it's not just about access to care, although that's part of it. Lower SES environments often come with more stressful life events. Think job insecurity, unsafe neighborhoods, that kind of thing. And crucially, fewer resources, financial, social, educational, to actually deal with those stressors. So, for example, low education is linked to more depression and worse functional status in some studies. There was one on rheumatoid arthritis patients where helplessness seemed to explain the link between lower education and dying earlier. And it can go both ways, too. Chronic illness itself, especially if it causes a work disability, can lead to a drop in SES. You see that with conditions like RA. It can become a difficult cycle.
That makes sense, the environment playing such a role. Does that extend to things like culture or ethnicity? How does our group identity fit in?
It definitely seems to. Ethnic group membership isn't just a label. It connects to identity, group pride, but also, importantly, experiences with discrimination. Now, the research here, especially long-term studies, is still developing, so figuring out the exact why behind the differences is ongoing. But we do see some patterns in cross-sectional studies, like higher psychological symptoms reported in some low-income Latina patient groups with cervical cancer. Or findings that African American and Latina cancer patients might be more likely to use spiritual practices as a way of coping compared to white patients. We see these differences, but understanding the deep mechanisms needs more work.
Interesting. And what about gender? Do men and women navigate this differently?
Yes, quite clearly in some ways. Generally speaking, women tend to report more depression, more pain, and more disability with chronic diseases compared to men. But it's not just symptoms. Research also looks at gender-linked personality traits, like agency, being assertive, focused on achieving goals that tends to link with better adjustment. Whereas something called unmitigated communion, basically, being overly focused on others to your own detriment, that often predicts more distress, and it's seen more often in women. Gender roles in relationships also play out. After a heart attack, for instance, men often cut back on work and are cared for more. Women, on the other hand, often jump back into household duties much quicker. And consistently, whether they're the patient or the caregiver, women tend to report higher levels of distress.
So those are the big picture societal influences. Let's zoom in now to the more immediate things. Personal relationships, individual mindset, the proximal factors. Where do we start there?
Social support is huge. Interpersonal relationships, having those resources, it's consistently one of the most powerful factors. Support helps in so many ways. Emotionally, just having someone there. Practically, like help with chores or rides to the doctor. It can also encourage better coping, better health habits, and even research suggests buffer the body's stress response physiologically. We see it in studies on rheumatic diseases. For example, good support links to fewer depressive symptoms, better function, sometimes even lower disease activity. It has real measurable effects.
It sounds like a cornerstone of adjustment, really. But can support ever be unhelpful? Can it go wrong?
That's a really important question. And yes, absolutely. Support isn't always positive. Sometimes it erodes over time. Sometimes it's just poorly timed or mismatched to what the person needs. There's research showing pain flares and conditions like arthritis are sometimes preceded by stressful interactions with people. And receiving support that feels disappointing or unhelpful can actually lead to worse adjustment, especially after something like a heart attack. Even communication breakdowns with the medical team can add significant distress. And it gets complicated within families, too. A patient's distress can sometimes lead to irritation or withdrawal from a spouse, which obviously undermines support. And when a partner is perceived as unsupportive, maybe avoiding the topic or being critical, that's a strong predictor of increased distress for the patient, particularly seen in cancer studies. So yes, it's definitely not always helpful.
Wow, that adds a whole layer of complexity. It really makes you think about how we offer support, not just that we offer it. Okay, moving inwards now. What about personality? Our basic disposition.
Yeah, personality attributes matter quite a bit. One that's studied a lot is dispositional optimism, just having a generally positive outlook on life. And the findings are pretty consistent. Optimism is linked to fewer depressive symptoms, faster recovery after surgery in some cases, more positive feelings day to day, and even lower reported pain. Why? Well, optimists seem more likely to use active, approach-based coping. They tackle problems. They also tend to appraise the illness situation as less threatening. And here's something really striking. Some studies suggest optimism might even predict survival. There was one study looking at cardiac patients over 10 years.
Wait, survival, like living longer.
Yeah, exactly. This particular study found that higher optimism roughly halved the risk for major cardiac events over that decade. It's pretty compelling evidence for that mind-body connection.
That is genuinely fascinating. So our outlook matters immensely. What about how we specifically think about the disease itself, our cognitive appraisals, the stories we tell ourselves about it?
That's absolutely central. How you view your illness shapes how you cope. Lazarus's theory is key here, the idea of primary appraisal, which is basically asking, is this harmful, threatening, challenging? And secondary appraisal, what can I do about it? Do I have the resources? Can I control this? So one big factor is perceived threats to life goals. If you feel the illness is blocking things you value deeply, your career, hobbies, relationships that causes significant psychological pain. We see threat appraisals predicting anxiety and depression in cardiac patients, for instance. Or NRA, losing valued activities is strongly linked to depressive symptoms. It's about what you feel you're losing. Then there are disease-specific expectancies, like beliefs about control and self-efficacy. Chronic illness obviously challenges your sense of control. Interestingly, people often feel they have more control over managing symptoms day to day, like pain, than over the ultimate course of the disease. And that sense of control over symptoms seems particularly beneficial. Feeling you have general control can reduce distress, say, in cancer patients. And studies in array suggest perceived control over symptoms helps more than trying to feel control over the disease progression itself, which might be unrealistic.
And you mentioned something earlier, related to this about spousing confidence. That sounded really interesting.
Ah, yes, that's a fantastic example of how interpersonal factors weave into these cognitive appraisals. It highlights the power of someone else believing in you. In a study on heart failure patients, both the patient's own confidence in their ability to manage and their spouse's confidence predicted survival. But when they looked at both together, it was the spouse's confidence that remained the significant predictor. It suggests that having a loved one who truly believes you can handle the challenges is incredibly powerful, maybe even more so than your own belief sometimes. Another really important appraisal is finding meaning. People search for meaning in two ways, generally: trying to make sense of why this happened, comprehensibility, and finding value or significance in the experience. This might mean seeing personal growth, stronger relationships, a new perspective on life. Some studies link finding these benefits, like interpersonal gains in RA patients, to better physical functioning later on. But it's nuanced. The research on benefit finding isn't always straightforward. Sometimes, especially early on, focusing too much on finding benefits might even be linked to poor adjustment. It's complex.
Okay, so we have the broad context, the relationships, the mindset. What about what people actually do? The coping processes. Are some strategies better than others?
Yes, definitely. Coping research often looks at this spectrum from approach to avoidance. Avoiding coping includes things like denial, suppressing thoughts, disengaging from the problem. And generally over time, avoidant coping tends to predict worse outcomes, more distress, poorer adjustment. We see this in breast cancer patients using cognitive avoidance, or in heart transplant patients, where avoidance linked to ongoing distress. It might feel better short-term, but it often hinders long-term adaptation. On the other hand, approach-oriented coping involves actively dealing with the situation. Things like seeking information, problem-solving, getting social support, expressing your emotions. These active strategies are pretty consistently linked with better adjustment across different conditions, like RA, where they relate to less pain and better mood. And what's really insightful is how coping interacts with other factors. For example, having high avoidant coping and low social support seems to be a particularly risky combination for developing distress. They influence each other.
Listening to all this, it's clear the field has come such a long way in the last couple of decades. What do you see as the biggest steps forward in understanding adjustment?
Well, I think there are a few key things. First, just conceptualizing adjustment in a much richer way. Moving beyond just symptom counts to include positive aspects like well-being and purpose, and recognizing it's dynamic, not static. Second, we have a much clearer picture of the risk and protective factors, thanks to better, longer-term studies. The positive impact of good relationships, optimism, perceived control, active coping, that's all pretty well established now. And third, the progress in biopsychosocial models is really exciting. Seeing concrete links between psychological factors like stress or depression and actual physiological outcomes, immune function, cardiovascular events, like that finding about depression doubling the risk of repeat heart problems after bypass surgery. It really drives home that mind and body are deeply interconnected.
That's incredible progress. But like any research area, there must still be gaps, right? What are the big unknowns or limitations that the sources point out?
Oh, for sure. There are definitely areas needing more attention. We still know less about those broader distal factors like the impact of community resources or even the physical environment of hospitals and how someone's life before the illness shapes their adjustment later on. Another big gap is understanding the interplay between different factors. How does personality affect which coping strategies someone uses? How do big things like SES interact with individual psychology? The source mentioned a study where health education actually seemed bad for cardiac patients high in negativity. We need to understand those interactions better. Also, the mechanisms behind some effects aren't fully clear, especially for cultural and ethnic differences. We see patterns, but the why is often missing. And the research hasn't been evenly spread. There's way more on certain diseases like breast cancer and certain populations, mostly white, higher SES individuals. Important areas like sexuality or spirituality are only just starting to get more focus. And maybe the biggest challenge is translation. We know a lot about what predicts good or poor adjustment, but actually turning that knowledge into effective interventions that help people in clinics and communities, that's still major work in progress.
So looking ahead then, where should the research focus? What are the next steps to fill those gaps and really move the needle?
I think the future really lies in integration, bringing together the environmental, the sociocultural, the biological with the individual psychological factors. Seeing the whole picture. Definitely need greater inclusion of diverse groups, people with very advanced disease, different ethnic backgrounds, and really digging into the mechanisms behind group differences, not just describing them. And a huge push needs to be on translation into interventions. Developing programs that target those known adjustment processes, like building self-efficacy or teaching approach coping. And critically, understanding how these interventions work. What pathways are they changing? Also, targeting interventions to those most at-risk people with low resources, maybe high negativity. And thinking about person-environment fit tailoring approaches. Someone high in avoidance might need a different intervention than someone who's actively coping but lacks support. Plus, using newer methods, maybe more experimental designs or studies that track people intensively day to day, could give us much deeper insights.
This has been fascinating. It really paints a picture of adjustment as this incredibly complex, dynamic, deeply personal process. It's shaped by everything from our internal thoughts to our social world to the broader society we live in. It's definitely not just about the body.
Absolutely. And understanding all these layers, it's not just useful for researchers or clinicians. It gives all of us, you the listener included, valuable insights. Insights for supporting friends or family facing illness, or even for navigating our own challenges in life.
Yeah.
It's about resilience, meaning, and finding ways to live well, whatever that looks like.
So reflecting on everything we've talked about today, the social factors, the personal mindset, the coping strategies, all these layers involved in adjusting to chronic illness, how might you rethink your own approach to well-being or how you support others facing long-term difficulties? Recognizing perhaps that true adjustment often goes far beyond just physical recovery.